You did the block perfectly. Correct technique, correct needle position, correct dose. And then your patient starts acting strange. Metallic taste in their mouth, ringing in their ears, slurred speech. You think maybe they're anxious, maybe it's the sedation. Then the seizure starts. Then the heart stops. Local anesthetic systemic toxicity is one of the most rapidly fatal events in anesthesia, and it can happen even when you do everything right. I'm Anesthesia Buddy, and today, last, local anesthetic systemic toxicity. Let's get into it. It's an elective procedure. 34-year-old female. Healthy, no significant history. Coming in for a shoulder surgery. You perform an interscalene nerve block, ultrasound guided. Correct positioning, correct needle trajectory. Negative aspiration before injection. You inject the local anesthetic. Ropivacaine, 30 milliliters. Everything feels routine. 4 minutes after the block, your patient says, "I have a weird taste in my mouth, kind of metallic." You note it. Maybe anxiety. 2 minutes later, "My ears are ringing." You look at her. Her speech is slightly slurred. Heart rate, 58. Was 72. She says, "I feel dizzy. Everything looks strange." Then her eyes deviate. Her body stiffens. Generalized tonic-clonic seizure. You call for help. Heart rate, 34. The monitor alarm screams. VFib. And now you understand exactly what this is. This is not anxiety. This is not sedation. The local anesthetic is in the bloodstream. This is last. Local anesthetic systemic toxicity. Last. What happens when local anesthetic reaches toxic concentrations in the systemic circulation? How does it get there? Intravascular injection, the most common cause. Even with negative aspiration, even with ultrasound guidance, the needle can enter a vessel between aspiration attempts. Rapid absorption from highly vascular tissue. Think intercostal blocks, paracervical blocks, interscalene blocks, all high absorption areas. Excessive dose. More drug than the patient can safely absorb. The mechanism. Local anesthetics block sodium channels everywhere, not just in the nerve you're targeting. In the brain, sodium channel blockade causes initial CNS excitation, as inhibitory neurons are blocked first. This gives you the early warning signs: metallic taste, tinnitus, circumoral numbness, agitation, confusion, seizures. Then, CNS depression, loss of consciousness, respiratory arrest. In the heart, sodium channel blockade slows conduction through the myocardium. Prolonged PR interval, wide QRS, bradycardia, ventricular arrhythmias, cardiac arrest. The most cardiotoxic local anesthetic, bupivacaine. It binds cardiac sodium channels with extremely high affinity and dissociates very slowly, described as fast in, slow out. This is why bupivacaine cardiac arrest is notoriously difficult to resuscitate. Ropivacaine and levobupivacaine are less cardiotoxic alternatives, but still capable of causing LAST. The progression to remember: CNS symptoms first, metallic taste, tinnitus, circumoral numbness, visual disturbance, agitation, then seizures, then CNS depression. Cardiovascular symptoms can occur simultaneously or shortly after. Do not wait for cardiovascular collapse to make the diagnosis. The window between first symptom and cardiac arrest can be less than 1 minute with bupivacaine. Act on the early signs. You have identified last. Here is exactly what you do. Right now, in order. Step 1. Call for help immediately and specifically say, "I need the lipid emulsion. This is last." Those words will get the right equipment to you faster. Step 2. Stop injecting local anesthetic. If you are mid-injection, stop now. No more drug goes in. Step 3. Airway management. 100% oxygen immediately. If the patient is seizing and losing airway, intubate. Prevent hypoxia and acidosis. Both dramatically worsen local anesthetic toxicity. Hyperventilate to create alkalosis. Alkalosis helps sodium channels recover faster. Step 4. Seizure management. Benzodiazepines first, midazolam or diazepam. If unavailable, propofol in small doses. Avoid large doses of propofol. It causes cardiovascular depression, which you absolutely cannot afford right now. Avoid lidocaine as an anticonvulsant. You don't add more local anesthetic to a last crisis. Step 5. Lipid emulsion therapy. This is your antidote. Intralipid 20%. This is the treatment that changed everything for last. Mechanism: the lipid sink theory. The lipid emulsion creates a lipid-rich compartment in the blood. Highly lipid-soluble local anesthetics, like bupivacaine, are drawn out of the tissues and into this lipid compartment, away from the heart, away from the brain. Dosing: bolus, 1.5 milliliters per kilogram of 20% intralipid 1,5. Push it fast over 1 minute. Then infusion, 0.25 milliliters per kilogram per minute. Continue for at least 10 minutes after cardiovascular stability is achieved. If cardiovascular collapse recurs, repeat the bolus. You can give up to 3 boluses. Maximum cumulative dose, approximately 10 to 12 milliliters per kilogram. Step 6. If cardiac arrest occurs, start CPR immediately. Standard ACLS, but with modifications. Use epinephrine, but use smaller doses than standard, 1 to 10 micrograms per kilogram, not the standard 1 milligram bolus. High-dose epinephrine in last can worsen outcomes. Avoid vasopressin. Avoid calcium channel blockers. Avoid beta blockers. If VFib, defibrillate, but recognize that bupivacaine cardiac arrest may require prolonged resuscitation. Do not stop early. The lipid emulsion needs time to work. Step 7. If refractory to all treatment, cardiopulmonary bypass, ECMO. This is the last resort, but it has saved lives in last. Know it exists. Call your cardiac surgery team early if things aren't turning around. Step 8. Post-resuscitation monitoring, ICU admission. Last can recur as lipid redistributes from tissues. Monitor for minimum 12 hours after an episode involving seizures. Minimum 4 to 6 hours after milder CNS symptoms. The board questions hiding in this crisis. Question 1. What is the antidote for last? Intralipid 20%. Lipid emulsion therapy. That answer is non-negotiable. Question 2. What is the mechanism of lipid emulsion? The lipid sink theory creates a lipid-rich compartment in blood that extracts local anesthetic from cardiac and neural tissue. Question 3. Which local anesthetic is most cardiotoxic? Bupivacaine. Fast in, slow out cardiac sodium channel binding. Cardiac arrest from bupivacaine is extremely difficult to reverse. Question 4. What modification do you make to ACLS during last cardiac arrest? Reduce epinephrine dose dramatically. 1 to 10 micrograms per kilogram, not the standard 1 milligram. High-dose epinephrine worsens outcomes in last. Question 5. What are the earliest warning signs of last? Metallic taste, tinnitus, circumoral numbness. These come before seizures. These come before cardiac arrest. These are your window to intervene. If a patient tells you they have a metallic taste after a nerve block, stop, think, act. Don't wait for the seizure to make the diagnosis. Know where your lipid emulsion is before you perform any nerve block. Know the dose before you need it. Have it drawn up and ready. The best resuscitation is the one that starts before the arrest happens. If this helped you, share it with someone doing regional anesthesia today. Subscribe to Anesthesia Buddy, because the best time to learn this is before you need it. I'm Anesthesia Buddy. Stay sharp. See you in the next one.